All right, let's dive right in. No long intros today. We're jumping straight into a rapid-fire Med-Surg prioritization drill to get your clinical judgment razor sharp. Ready? Let's go.
First up, we're tackling breathing and airway crises. So, picture this classic scenario. Your patient's breathing is starting to fail. Here's exactly what's going on.
Okay, here's our patient, a client with severe COPD, on 2 liters per minute via nasal cannula, suddenly becomes restless and confused. Their vitals are temp 37.0, heart rate is 112, respirations are only 10 and shallow, BP is 142/86, but look at this, their SpO2 is 99%. So which action should you, the nurse, take first? Is it A, increase oxygen to 6 liters per minute? B, obtain an ABG? C, elevate the head of the bed and perform a focused respiratory assessment? Or D, administer a PRN anxiolytic? Pause here. What should the nurse do first?
Okay, the correct answer here is C. You have to elevate the head of the bed and do a focused assessment. Here's the deal. That new confusion combined with a respiratory rate of just 10, that's a huge red flag. It's screaming CO2 retention and respiratory failure, even though that SpO2 of 99% is trying to trick you. Your absolute first move is to improve their ventilation. Get them sitting up, listen to their lungs. Now, why not the others? A is a big no-no. Cranking up the oxygen can actually knock out the respiratory drive in some COPD patients. B, getting an ABG, yeah, you're going to need that, but it's a test. It doesn't do anything right this second. And D, giving an anxiolytic, wow, that could be a disaster. It would depress their breathing even more. You've got to assess first, always.
All right, let's lock this in with an NGN exam tip. Your strategy. When you see a low respiratory rate plus new confusion, your brain has to immediately go to critical breathing problem. The framework? This is classic ABCs. We are squarely in B for breathing territory here. And the trap? Don't fall for that shiny 99% SpO2. It's a distractor. The real danger signal is that shallow respiratory rate of 10. Don't just reflexively turn up the oxygen.
Okay, let's shift gears. We're moving from breathing to our next section, circulation and perfusion shocks. This is where we talk about the heart of the matter, quite literally. These are the patients who are circling the drain, and your first move is everything. Okay, new scenario. You have a client with cirrhosis who starts vomiting bright red blood. Vitals are heart rate 132, blood pressure is way down at 84/50, and they're breathing fast at 26. So what is your very first action? A, insert an NG tube for lavage. B, place the client in a supine position. C, initiate large bore IV access and start isotonic fluids per protocol. Or D, administer lactulose. Pause here. What should the nurse do first?
The correct answer, without a doubt, is C. You need to get IV access and start fluids. Like yesterday. Look at those vitals. A heart rate of 132 and a blood pressure of 84/50. That is the textbook definition of hemorrhagic shock. This patient is bleeding out. Your priority is circulation, period. You need to pump volume back into them. Now let's look at why the others are wrong. A, an NG tube? That's for later. It's a diagnostic, not a rescue. B, putting them flat with active vomiting of blood? That's just asking for a massive aspiration. And D, lactulose? That's for ammonia and cirrhosis. It does absolutely nothing for a life-threatening bleed.
So here's your NGN takeaway, the strategy. In any massive bleed, your mantra should be volume first, volume first, volume first. Get that access, hang those fluids. The framework is still our good old ABCs, but we are laser focused on C for circulation. And what's the trap? Getting distracted by secondary tasks, like inserting an NG tube, when the patient needs life-saving resuscitation right now.
All right, next case. A client with type 1 diabetes comes in. They're confused, they have those deep, rapid Kussmaul respirations, and you can smell that fruity breath. Blood glucose is 560, and their blood pressure is tanking at 92/58. So, what do you do first? A, start an IV regular insulin infusion. B, administer an IV normal saline bolus. C, administer sodium bicarbonate. Or D, give subcutaneous rapid-acting insulin. Pause here. What should the nurse do first?
The answer here is B. Give that IV normal saline bolus. Look, I know it's tempting to jump on that crazy high blood sugar, but that blood pressure of 92/58 is your real emergency signal. This patient is in DKA, which means they are severely dehydrated and hypovolemic. You have to fill the tank with fluids before you give insulin. Why is that so important? Well, if you give insulin first, it's going to pull sugar and water from the bloodstream into the cells, and that low blood pressure will drop even more, potentially causing a total cardiovascular collapse. As for the others, bicarb is a last resort for severe acidemia, and sub-Q insulin, just way too slow for this crisis.
Let's nail down the NGN tip for this one. The strategy is super simple to remember. When a DKA patient is hypotensive, it's always fluids first. The framework we're using is circulation before correction. You have to stabilize the circulation before you start correcting that high glucose. And the trap? It's a huge one and so easy to fall into, jumping straight for the insulin because of that big number on the glucometer. You gotta resist. Fluids first.
Okay, we're heading into our final section, critical complication management. These are the scenarios where recognizing the problem and making the right first move can literally be the difference. Let's do it.
Here's the situation. A client with chronic kidney disease has a potassium of 6.7. That's critically high, and their ECG is showing those classic peak to T waves. The provider has written a bunch of orders. Which one do you carry out first? Is it A, sodium polystyrene sulfonate? B, regular insulin IV plus dextrose? C, furosemide IV? Or D, oral sodium bicarbonate? Pause here. What should the nurse do first?
The correct answer is B, regular insulin and dextrose. And this is all about speed. Those peaked T waves are a massive warning sign. They mean the heart is becoming super irritable and could flip into a fatal rhythm at any second. Your number one job is to protect the heart right now. Insulin and dextrose is the fastest way to do that. It literally shoves potassium back into the cells, stabilizing the cardiac membrane. Now, what about A, the sodium polystyrene sulfonate? That actually removes potassium, which is good, but it works in the gut, and it is way too slow for this emergency. C, furosemide? Slow and probably won't work well in a CKD patient anyway. D is not a first-line treatment. Heart first.
Let's lock in this NGN tip, because it's a big one. Your strategy. You see a critical potassium level plus ECG changes. Your only goal is to find the fastest-acting, heart-stabilizing intervention on the list. The framework here is urgent versus non-urgent. Those T waves just upgraded this whole situation to critically urgent. And the trap is choosing an answer that actually removes potassium from the body, like the binder, over the answer that protects the heart from that potassium, right now. Save the heart first, remove the potassium second.
Okay, last one for our drill. You're 10 minutes into a packed red blood cell transfusion, and your patient suddenly develops chills, back pain, and starts wheezing. What is your absolute first move? A, slow the transfusion rate. B, stop the transfusion and keep the IV line open with normal saline. C, obtain a urine sample. Or D, notify the blood bank after you finish the unit. Pause here. What should the nurse do first?
The answer, and there's only one right answer, is B. You stop the transfusion. Period. Full stop. These are hallmark signs of an acute transfusion reaction. Your first, last, and only priority at this moment is to stop the offending agent. Disconnect the blood and keep that IV line open with normal saline because you're going to need access for emergency meds. A, slowing the rate. That's like slowing down how much poison you're giving someone. It's still poison. C, getting a urine sample. Yes, that's on the to-do list, but not before you save the patient's life. And D, finishing the unit. Absolutely not. Never, ever, ever. That's a catastrophic error.
And for the NGN tip, this might be the simplest one of the day. The strategy is one word: stop. If you suspect a transfusion reaction, the only thing your brain should be thinking is STOP. The framework we're using is safety and risk reduction. Your job is to prevent any more harm from happening. And the trap, the most dangerous trap here, is thinking that just slowing the infusion is a safe first step. It is not. You have to stop it completely. And that's a wrap on our prioritization drill. I want to leave you with this thought. In an emergency, prioritization isn't just about passing a test. It's the difference between the right first action and the last possible one. Thanks for joining me.